التسليفه دي الدكتور محمد جمال الاشهر طبعا يعني كراجل
العلم بتاع مصر والحاجات الحلوه بتاعتك دي خاصه بيك انت دايما.
الله يخليك.
جميل.
الله يخليك، بنهنيه بالعماده وربنا يكرمه ويجعله ميزان حسنات
وربنا يعينه.
ربنا يدي سعادتك الصحه يا استاذ.
ربنا يعينه.
طبعا اخونا الدكتور طبعا من الناس اللي ليهم بصمه، ويعني انسان محترم في علمه واخلاقه يعني، فمن الناس اللي تعرفنا بهم يعني ترجع الى سنوات يعني كبيره جدا يعني. فنشكره على المحاضره الجميله. الله يخليك. My talk today about non-bony knee injuries. احنا اول بنسمع عن non-bony injuries على طول بنروح على المنسكس وعلى اللاترال كولاترال ليجمنت وميديال كولاترال ليجمنت والمنسكاي. فالنهارده بس هنعمل هايلايتنج على حاجات كده بنبقى اسمها soft tissue injuries of the knee. فالني طبعا ده هيدك مش حاجه صغيره. الني دي a big joint و big problems ولازم نفكر فيها لانها تعمل disability ل all the patients. فده review of the course and function anatomy. ده knee injuries. Discuss the traumatic injury of the knee. أهم حاجة discuss overusing injury in and about the knee and discuss the sign and symptom of a specific injury with causes and treatment. The knee anatomy كلنا all people know about it. It's a large joint, synovial hinged joint. وبعدين بتتكون from bone, 4 bones, the femur, tibia, patella, and fibula. Each articular covered with hyaline cartilage. طبعا ligament اللي هي dense structure of the connective tissues that fasten bone to the bone and stabilizing the knee. Inside the knee there are 2 major ligaments, an anterior and posterior cruciate ligament, with 2 other ligaments located outside the knee اللي هو medial and lateral collateral ligament. The patellar tendon connecting the lower bone of the patella with the upper part of the tibia. In menisci, we know that we have 2 menisci اللي هي shock absorber their function and is spreading the weight over the tibial plateau. A range of injury of the knee اللي هي منها many types of injuries اللي هي traumatic synovitis, mechanic meniscal tear, ACL rupture, patellar dislocation, OCD, collateral, BC, PLC, and combined injury. فلما نيجي نبص broadly classification اللي knee injury can be soft tissue injuries or bony injury or combined soft and bony injuries. So the soft tissue injury of the knee are some of the most common and clinical challenge in musculoskeletal disorder in the patient presenting to the ER. Soft tissue structures that stabilizing and cushioning the knee joint including ligaments, muscle, tendon, menisci. One of these or both or combined can lead to disability. This is diagram show a lot of the condition which can be occurred due to soft tissue injuries. So we can classify this as what we call the internal derangement of the knee. This classification is traumatic as a synovitis, hemoarthrosis, injury to the medial and the lateral or cruciate ligament, injury to the semilunar cartilage, dislocation of the knee, and the loose body of the knee. The injury to the external mechanism of the knee, like avulsion of the quadriceps, fracture of the patella, avulsion of the ligamentum patellae, injury to the tibial, tubercle, and Osgood-Schlatter disease, dislocation of the patella, and the lastly bony injury is the fracture of distal femur and proximal tibia. So what do you mean by internal derangement of the knee? Internal derangement of the knee is an internal disturbance involving disruption of the normal function of the ligament or the cartilage, menisci of the knee joint that resulting in pain and movement obstructions. Of all the ligaments, there are 4 ligaments which are commonly injured and they can be classified as for intra-articular, extra-articular, anterior cruciate, posterior cruciate, extra-articular, medial collateral ligament, lateral collateral ligament, and all of this has been common injuries occur to the patient. Anterior cruciate ligament, a lot of people know about it. Posterior cruciate ligament has been mentioned before, and the ligament of the injury as one of these mentioned by Professor Dr. Maher Hassan now. Collateral ligament, medial collateral ligament, lateral collateral ligament, menisci injury, and we know about the meniscus is we two menisci, and the tear, which can be occur medial or lateral, and it can be bucket handle tear, anterior horn, posterior horn, and this is a common meniscal injury and the other type of classification. And this is an example of arthroscopic meniscal tear, and this is another one, and this is the MRI showing the meniscal tear and the ligament injury. So the classification of the ligament itself, it can be going from sprain or tear to the medial collateral ligament, or sprain or tear to the lateral collateral ligament, or partial or complete rupture of ECL, or rupture of the BCL, tear of the medial semilunar cartilage, or tear of the lateral semilunar, or tear of degenerative menisci, or cyst of the semilunar cartilage. So we have two things which can be affecting the ligament, either sprain or strain. What is meant by sprain? Sprain is characterized by the stretching or tearing of non-contractile structure, such as investing ligament or the joint capsule itself. But the strain is characterized by stretching or severing along the course of the muscle or tendon. Both collateral ligament and cruciate ligament sprain will, as well as muscular strain, are relatively common. What about the grade, as mentioned by Professor Maher, about the grade of the sprain? It can be from grade 1 to grade 3. Grade 1, sprain is stretching but not tearing of the ligament, local tenderness and the minimum edema, no gross instability with a stress test, and it is firm endpoint. But the grade 2 sprain, it is partial tear of the ligament, moderate local tenderness there, and mild instability with a stress test, but firm on the blade and moderately incapacitating. The last one, which is the grade 3 sprain, a complete tear, there will be discomfort with manipulation, but less than expected for degree of injury. Variable amount of edema ranging from negligible to gross edema, and clear instability with the stress test, and there is severe disability. So for this, you have to know that there is accurate diagnosis can be by knowledge of the knee anatomy, common pain pattern in the knee injury, future of the frequent encountering causes of knee pain, and the history should be including characteristic of the patient, trauma and pain, mechanical symptoms like looking, popping, giving way, joint effusion if present or not, what is the timing, what is the amount, and the recurrent, and also the mechanism of injury. This is an example of some sort of knee injuries that can be occur. It can be classified into according to the site of the injury. So this is the pain according to the presenting of the tender point. So we can make roughly distributing about the knee injuries. Anterior knee pain can be due to idiopathic, infrapatellar bursitis, Hoffa syndrome, patellar stress fracture, syndrome Larson-Johnson syndrome, Osgood-Schlatter, multi-artita patella, osteochondritis dissecans, patellar tendinopathies or tendinitis or quadriceps tendinitis. Posterior knee pain like hamstring tendinitis or posterior, and corner injuries are symptomatic persist. Medial knee pain from osteochondritis dissecans, base ulcers, semimembranous bursitis, medial meniscal tear, pathological medial plica, base ulcers tendinopathies, and semitendinous bursitis. Lateral knee pain, discoid lateral meniscus, popliteal tendinitis, saphenous nerve entrapment syndrome, iliotibial band syndrome, lateral meniscal femoral nerve entrapment neuropathies. So we will go for some of what we call non-bony knee injuries, which is common, and a lot of people can be missing and always concentrating about that the knee injury means a meniscus or ACL. But we have a lot of things which is called non-bony knee injuries. This one, the first one is the iliotibial band friction syndrome. It is a discomfort over the lower two-thirds worsened by running downhill. This is coming from overuse injuries or over using training, and the cause is mainly due to the presence of single long hard running, rapid increasing in the training distance أو bunker surface running اللي هي pitch or shoulder of the road or excessive heel running. This is what we call bunker surface running and leading to stress, which leading to the iliotibial band friction syndrome. The etiology always due to limb lengthening discrepancy, which make a stress on the knee, genovirum, overpronation, hyperadductor weakness, hip abductor weakness, or myofascial restrictions. This is like unbalanced repetitive exercise, excessive training, and faulty in the biomechanics of the leg. So the mostly always patient is young, athletic, and mostly as the lateral aspect of the knee, but can overlay the hip. Female common more than the male. The pain on cross leg and standing with leg crossed, extending from the lateral hip to the lateral knee. This is an example of cross leg, which leading to the iliotibial band syndrome. Always the patient complaining of crepitus, pain in pain on compression of the lateral femoral condyle. Always look for the stretching iliotibial band. Look for, when you examine, look for the leg malalignment, leg length discrepancy, excessive foot pronation, pelvic contralateral downward tilt. This is a point where you can elicit the iliotibial band friction syndrome, and this is the iliotibial band, how to elicit it during examination. And this is the examination of iliotibial band by pressing on the heel, trying to pushing the patient forward, and you will feel that the iliotibial band. We have two tests, which is a common test, Hoffa test and Doppel test, to examine the stretching of the iliotibial band. And we mentioned this before during our examination of the knee. The treatment, we have we have many lines. The first line is reduction of training distance, non-steroidal daily stretching of the iliotibial band, corrective orthosis for the foot pronation, stretching the ipsilateral hip adductor pelvic drop on gait analysis. The second line of the treatment, local infiltration by corticosteroid. The third line, surgically by dividing the iliotibial band about 3 centimeters above the lateral femoral condyle, make a V shape, which make to release the iliotibial band. The next one, which is the popliteus tendinitis. This is the popliteus tendinitis, is a tear in the popliteus tendon. When you have a tear, this will lead to a severe pain in the posterior aspect of the knee. The popliteus tendon is surrounding the posterolateral aspect of the knee, stabilizing in the flexion by resisting forward displacement of the femur on the tibia. Less common, but the same causes of the iliotibial band, and it can be going as a differential diagnosis. The patient will complain of discomfort behind the lateral collateral ligament and with resistance the knee flexion with the tibial held in external rotation. The treatment of the popliteus tendinitis is reduction of the training distance, give him non-steroidal anti-inflammatory, stretching of the knee flexor, electrotherapy, corticosteroid agent. Avoid overstraining or overtraining or overuse. This is an example of the training, stretching knee flexors and to overcome the popliteus tendinitis. The third one, which is the patellofemoral joint pain syndrome, defined as a retropatellar or pre-patellar pain resulting from physical and biochemical change in the patellofemoral joint. Common in the female more than the male because the Q angle. The pain under the kneecap worsened by descending or climbing the heel or strain, the people who using the knee like football. Pain sitting down for the long period, leading to the patellofemoral pain syndrome. Most often seen in athletic, presenting in adolescent and in the 4th and 5th decade. Any sport could be associated with patellofemoral joint dysfunction and pain syndrome. The pain is combination of repeated increasing of pressure over the subchondral bone and the tightening retiniculum structure. Pressure over the articular cartilage affecting the nutrition and resulting in degenerative change. Always don't forget about the vastus medialis, which is dysfunction and responsible. This dysfunction leads to failure to compensate tendency to the lateral shift of the patella, which leading to the patellofemoral syndrome. Always the patient complaining of crepitus, irritability of the patellofemoral joint, a small swelling, mild effusion, quadriceps wasting and weakness, and the wasting of the vastus medialis. This is an example of the wasting of the vastus medialis. From biomechanical factors, the wide Q angle is above 16 in male and 18 in the female, leading to patellofemoral syndrome. Genovalgum leading to mild subluxation of the knee and the malalignment of the movement of the patella over the condyle of the femur. Shallow intracondylar notch, pronating gait, which increase the internal rotation of the tibia, leading to patellofemoral joint pain syndromes. Chondromalacia patella is the pain underneath the patella with the possible of popping or crepitus, especially in the 60 and 90 degree range of motion. It is always you can elicit by direct pressure, may elicit the pain, and the lateral retiniculum play. Straining and the prolonged sitting are almost the problem, causing including large Q angle, lateral riding, or subluxation of the patella and overuse and muscle imbalance. Sometimes we have traumatic subluxation of the patella or traumatic dislocation, and it can be occur, giving way by sensation, popping and the local tenderness and positive apprehension test, and this is common in female of adolescent age, causing including contraction of the quadriceps with medial blowing or external rotating foot, a small lateral condyle, tight lateral retiniculum. Dislocation, which is more severely, if the patella is out, the knee is severely deformed, painful flexion, and the patella are normally on the lateral side of the knee, causing are the same as subluxation of the patella. Always you can examine for the patellar test by patellar gliding, patellar tenting, and the patellar grounding test. This is the patellar gliding, which is movement assesses the patellar mobility, and you can elicit the patellar abnormality. And this is patellar grounding test, which can be done by passive or active, crushing sensation transmitting through the patella. Patellar grounding test, which is elicit the patient is in the supine position with the knee extending. The examiner displays the patellar inferior into the trochlear groove, and the apprehension test will be okay. This is the patellar test, the positive test. The lateral aspect of the patella is fixed and it cannot be raised to at least horizontal position. If it occurs, this is a positive patellar test. Apprehension test, and this is an example of the CT, and this is the axial view of the patella, so patellar subluxation, and this is the bipartite patella. The treatment of BFJ, vastus medialis re-education exercise, is very important. You can use conal strapping or drop squatting exercise, eccentric drills for 6 to 8 weeks, surgical debridement and the lateral release, patellar tendon and the realignment to correct the Q angle. This is an example of strapping, McNor and Kinsey and Sham. This is to avoid the mal-tracking of patellofemoral joint, and this is a drop squatting exercise for to prevent the patellofemoral mal-tracking syndrome. Patellofemoral synovial plica. This is a normal plica, but can be pathological due to overuse, training, and trauma. The medial suprapatellar plica of the knee is an intra-articular synovial form on the medial aspect of the knee. The remnant of the septum of the embryonic joint usually presenting but always asymptomatic. And this is the presence of plica. Many types of plica we have, but the medial plica is the most common one. It's coming as a pathological due to overuse or traumatic. This is a medial plica. And this is an example of different plica. Symptomatic plica, the medial patellar plica running from the superior patellar pouch to the inferior patellar fat pad and the impinge of the medial femoral condyle and patellofemoral joint fat pad syndrome. This is a symptom of the patient, always anterior knee pain. There is a snapping, there is a click, catching, tender to the touch, felt as a tender band underneath the skin. Knee, sometimes will be knee effusion with the swelling and the pain on squatting and the looking stiffness and giving way. Always when it is the plica, felt the band immediately, the mild knee effusion, pain on the resistant knee extension, make worse by gliding the patellar medial. Always you feel the patella if you, in the infromedial part, the medial plica can be felt. This is what we call the plica. The patient indicates the painful area by his index. The infromedial quadrant is usually the most painful region, and this is very important. The patient can be elicited with the pain. A painful tight band of tissues that emanate from the central portion of the medial patella may often be palpated. Secondary, always this plica syndrome, always second to injury or overuse, and it is inflammatory process. Normally, plica hypertrophied into a truly pathological structure. There's many tests can elicit the plica. This is the Higginson test or plica test, Suter test. This is the Higginson test, which is internal rotation and pressure on the infromedial part of the patella. Extending will lead to elicit the pain. The plica test by index, and this is the Suter test to elicit the plica after to elicit the pain. That treatment always rest, non-steroidal corticosteroid if medial plica palpated arthroscopic excision. This is an example of the plica and the infrapatellar fat pad syndrome, Hoffa syndrome. It is a common and misleading. It is an anterior knee pain, and there is a pain under the patella, and there may be effusion. Very often misdiagnosis or not diagnosis at all. The causes is repetitive hyperextension injury for the patient who has ligament laxity, in the patient who frequent ski or and running, surgical intervention sometimes leading to the Hoffa syndrome, part of the patella baja, short patellar tendon from the fibrosis, previous surgery and blocking the knee flexion. The Hoffa syndrome is a pain on hyperextension over the anterior knee region, tenderness and or swelling around the bottom and under the kneecap. Patient maybe have history of knee hyperextension injury like recurvatum. In some cases, the bottom of the kneecap may be tilted outward due to the swelling underneath. This is an example of hyperextension of the knee due to leading to a Hoffa syndrome. There is an Hoffa positive test, which is very important, and you can elicit it. It's very simple. You can press over the two sides of the patella and ask the patient to extend the knee. If he expresses some pain, this is positive Hoffa test. Always don't forget to do an X-ray. Sometimes from repeated can lead to calcification of the person. And this is an example of this. And this is an MRI representing the Hoffa test, Hoffa disease. Treatment always rest from hyperextension, non-steroidal, electrotherapy, arthroscopic excision, and this will lead to significant fibrosis can lead from this as a complication. We have a patellar tendon injuries, which can lead to, and according to the area, inferior pole of the patella, if the injury leading to Sender-Larson-Johnson syndrome, the tendon overstretching or trauma to the patellar tendon leading to patellar tendinopathy or patellar rupture, patellar insertion as the tibial tuberosity, overstretching leading to Osgood-Schlatter disease. This is an example from minor trauma, what we call non-bony knee injuries, house-made knee, like swelling anterior to the patella. There will be nodule formation can be seen or palpated in the prepatellar bursa in the chronic inflammation. There is another one which is coming, was called Crickman's knee due to trauma to the anterior part of the knee. Due to the infrapatellar bursitis, the Crickman's knee. It is the inflammation of the infrapatellar bursa located just below the knee due to repeated stress or brain. This is the difference between the two types of the anterior knee pain: Clerkman knee or house-made knee or deep infrapatellar bursitis. Jumper knee, which is another type from overuse or injury to the patellar tendon. It is called the patellar tendinopathy. It is due to repetitive extension action of the knee with the generation of large eccentric force. The biomechanical analysis of the basketball, if the people who do jumper knee or jump knee, jumping or loading force applying the greatest tensile forces on the patellar tendon when in landing. This will lead, there will be history of tendoperiositis of the lower pole of the patella, granulation of the tendon deepening in its sheath and due to degeneration. The patient always in jumper knee complaining of gradual onset pain or lower pole of the patella associated with increased retraining load and always coming in acute. On examinations, there will be a tenderness, always a swelling, crimpus local over the tendon, quadriceps tightening may be due to the bursitis. This is an example where is the presence of jumper knee. You can elicit by ultrasonography or by MRI. There will be defect within the tendon. You can diagnose this easily. The treatment always in an acute stage, active rest, ice, non-steroidal, 6 weeks recovery. In the chronic stage, there is a thermal, heat retained with sleep, eccentric exercise and rope squatting program, and the strengthening exercise. Sometimes footwear tracking surface tapping patellar tendon can help. Surgery sometimes may be needed by excision the inferior pole of the patella and scarring from the tendon, and repair the tendon, and they need 6 months recovery from this surgery. Single Larson disease, this is an traction osteochondritis of the lower pole of the patella, coming always in younger patient. Pain over the inferior pole border of the patella is the presenting complaint. The disease is similar to the Osgood-Schlatter disease, but occurred 1 to 2 years earlier. Suprapatellar bursitis, it is a traumatic bursitis, can be occur. It can be irritated by the direct flow or from repetitive stress or motion. There is generalized swelling of the knee above and behind the patella. Suprapatellar bursitis is a common complication after trauma or knee surgery. ANSERINUS bursitis, as mentioned, this is bursa inflammation as a medial aspect of the upper tibia. It is typically affected athletic, especially running and swimmers, due to overuse or overweight. Middle-aged female due to increased pressure through the person. Always the causes is by tight hamstring muscle, inadequate stretching, and the previous hamstring injuries. It is a painful condition, and it is a painful inflammatory condition affecting the tendon and or its replicant sacral bursa between the tibial and the hamstring tendon at the inside of the knee, typically caused by stress to this area. The ANSERINUS is a burning localized pain when running, pain and swelling over the medial aspect of the knee. And this can be elicited easily by MRI, and you can see this in many pictures. The treatment of ANSERINUS bursitis is always stretching hamstring, non-steroidal, best when acute, rest when acute, local infiltration, and orthotics. This is an hamstring stretching exercise to overcome the bisantherous bursitis. Semibronous bursitis is one of the common injuries can be occurred due to the semibronous persona between the semibronous muscle and the medial head of the gastrocnemius. This person may become enlarged and presenting as a painful lump on the medial part of the popliteal fossa due to overuse or strain. It is overuse and more from the training. On examination, there is a lump, is flagrant, and it cannot be pushed into the joint, and the knee joint is normal. This is how to differentiate it between in the MRI between gastrocnemius tendon and semibronous tendons bursitis. The treatment is rest, non-steroidal physio injection, and excision of the pulse. This is another type of injury which is occurred due from overuse or strain due to traction of bursitis, a repeated avulsion of the apophyseal into which is a part of the patellar tendon is inserted. Occur at preparatory growth, spurt, quadriceps has enlarged, but the apophysis has not yet fused to the tibia. This is an example of Osgood-Schlatter disease, which affecting as shown in the X-ray. This is Osgood-Schlatter disease. Always patient complain of pain, tenderness, and lump over the tibial tuberosity and pain after the activity. And always coming to your clinic, always a young child or young person or an adolescent who is suddenly playing a football or a different type of squatting and leading to the anterior knee pain. The treatment of this condition is rest, non-steroidal, rare plaster of Paris for rest, and even rare excision of the spicula of the bone. This is an example of traumatic injury that can be occurred due to avulsion injury of Osgood-Schlatter disease. Picker cyst, which is a dull aching pain and the full feeling behind the knee due to an inflammation of semibronous tendon or the medial gastrocnemius bursa. It is more advanced stage. There is a palpable lump in the popliteal fossa, sometimes due to the herniation of the tendon sheath. The Picker cyst is often indicated underlying pathology such as medial meniscus injuries. Lateral bursitis, it is a fibral bursitis due to the lateral strain or varus strain of the knee. The pain proximal to the head of the fibula caused by friction force between the lateral collateral ligament and other structures. It is difficult to differentiate it from other problems. Popliteal bursitis, which is a popliteal bursitis, is a swelling that caused from the fluid coming from the knee, that protruding to the back of the knee. The most common injuries can be occurred due to hyperextension is hamstring tendinitis. We have two types: high hamstring tendinitis, which is affecting the ischial tuberosity, and this is coming for the runner, and low hamstring tendinitis, which is the pain and tenderness over the insertion of any of the three heads of the hamstring muscle. There will be crevitus, and the swelling can be felt with the deep palpation of the tendon, and muscle are painful. This is what we call hamstring tendinitis. The cause of hamstring tendinitis can be insufficient warm-up or injury while playing sport, or poor strengthening can lead to hamstring tendinitis and one of the non-bony knee injuries. Gastrotendinitis, which is pain on the posterior aspect of the knee associated with either head of the muscle. Remember to control the knee movement when isolated the pain. This can be differentiated between many conditions like Charlie horse, and we will speak about it, plantaris muscle rupture, tendinitis, tennis leg, calf muscle contusion, soleus muscle strain, and DVT. This is a Charlie's horse or calf muscle spasm or cramp, referred to an involuntary contraction of one or more of the calf muscle. Muscle cramp in the calf are often reported as intense pain and being associated with stiffness and a visible node. Although this uncontrollable tightening of the muscle is generally short-lived, calf muscle soreness and may be persistent for days. And this is what happened during the people who's during play. So for non-bony, what we call the non-bony knee injury, can be differential diagnosis for a lot of conditions. Is it anterior cruciate? It is a medial synovial plica. It is a contusion. It is patellofemoral. It is iliotibial band, bis anserus, knee osteochondritis, posterior cruciate ligament, lateral collateral, lumbosacral, medial collateral, articular cartilage, crystal deposit. All these are condition of non-bony injuries of the knee. So the treatment as a whole, it is we can classify this condition into acute rehabilitation program and physiotherapy program. In acute, use what we call prisma, what we call protecting range of motion brace. Rest may be required crouching if significant pain or instability with weight bearing. Ice for 20-minute TID. Compression ice wrap when may help control excessive edema. Elevated above the heart if possible. Medics like non-steroidal non-steroidal anti-inflammatory modalities to use electrical stimulation may help reducing the pain and inflammation. In conclusion, sorry for that, this is my last slide. In conclusion, that the knee injury, it can be bony injury, soft tissue injury, or combined of the above. And thank you for your listening, and thank you for Professor Muhammad for inviting me for this condition.
Thank you so much, Professor Baha, for this very interesting talk, sir. Thank you so much. Sir, we have two questions من أخونا العزيز دكتور إبراهيم قمر من Sligo University Hospital من ايرلند. دكتور إبراهيم طبعا يعني صديق عزيز وحضرتك عارفه كويس يا فندم.
طبعا إبراهيم حضرنا معاك كذا محاضرة.
دكتور إبراهيم بيشكر حضرتك جدا على amazing presentation, and he has two questions. First question, what's your opinion, sir, on patellofemoral joint replacement?
It is, I think it is under trial, and if you have isolated, you have to has isolated indication, it can be done. But I think patelloplasty, it is better. I think for my knowledge, we did a lot of total knee, and we do a patelloplasty in tricompartmental osteoarthritis, and it's giving for us good result. But for this isolated patellar osteoarthritis, I think it is under trial and they needed a lot of, we have to go for literature, and we need a lot of research for this, because the knee, it is a knee complex. It is a complex joint. It is not a single joint.
Yes, sir. Second question من دكتور إبراهيم. When you decide to go for surgical intervention or repair of medial patellofemoral ligament?
The post-traumatic, and you have an, if you do an X-ray and there's still instability, and I think this patient needed for reconstruction of the patellofemoral joint, and there is a lot of methods that have been advocated now for this type of injuries, and you can do it arthroscopically or you can do it by open.
تمام يا فندم. دكتور بهاء، انا هستاذن سعادتك نستوب شيرنج يا فندم.
حاضر.
Any other questions to Professor بهاء؟ يعني احنا في نهايه اليوم الجميل ده بنشكر حضرتك استاذنا الكبير استاذ دكتور بهاء بيه قرنا على الكونتينيوس سبورت اللي حضرتك مديه لنا، وطبعا بنشكر استاذنا الكبير استاذ دكتور ماهر بيه العسال من طب اسيوط على تواجده معانا النهارده، شرف كبير لنا. احنا حضرتك بنستاذن حضراتكم، احنا الاسبوع الجاي احنا اجازه لان احنا بنجهز للسبيشاليتي دايز. السبيشاليتي دايز ده مشروع جبار ان شاء الله. احنا هيبقى في كل شهر اول خميس وجمعه في كل شهر هيبقى سبيشاليتي داي. هنبدا بالسباين سبيشاليتي داي زي ما حضراتكم شايفين، هيبقى في ناشونال وانترناشونال سبيكرز دول الناشونال سبيكرز التوب ايميننت ستارز في مصر. هيبقى دول الناشونال. الانترناشونال دكتور عمرو اديني الانترناشونال سبيكرز. انترناشونال سبيكرز هيبقى معانا انترناشونال سبيكرز من المكسيك، من ساوث كوريا، من الهند، من الصين، من تركيا، من اوكرانيا، من الفلبين، من بولندا، من كندا، من يو كي. فيعني كولكشن كبير قوي من الانترناشونال سبيكرز. السبيشاليتي دايز مش هتبقى محاضرات بس، هتبقى محاضرات، هيبقى في لايف سيرجري ان شاء الله، هيبقى في ورك شوبس لايف. في بعض الحاجات هيبقى في كادافيريك ورك شوبس هتبقى ترانسميتد دايركتلي فروم كادافيريك لاب لارثريكس من ميونخ من المانيا. فيعني انا اسف، الاسبوع الجاي احنا هنبدا نحضر لده على مستوى عالي قوي ان شاء الله، فده بياخد تحضير مني وقت طويل قوي. فان شاء الله باذن الله هنبدا بالسباين سبيشاليتي داي، والاسبوع اللي بعده هنكمل في الكورس بتاعنا عادي، وهيبقى الشهر اللي بعده ان شاء الله هيبقى الشولدر سبيشاليتي داي، واحنا بنوعد حضراتكم بالتوب ايميننت ستارز في العالم للشولدر سيرجري ان شاء الله. فان شاء الله نسعد بوجود حضراتكم معانا في السباين سبيشاليتي دايز يوم الخميس والجمعه 1 و2/7. الخميس هيبقى من الساعه 8 للساعه 12 مساء، والجمعه هيبقى من الساعه 3 للساعه 8 عصرا، على اساس فروق التوقيت ما بين الناس السبيكرز اللي في الصين وساوث كوريا والفلبين، وفي نفس الوقت اللي في كندا واللي في المكسيك، لان يعني في اختلاف كبير قوي في فروق التوقيت، وكلهم هيبقوا لايف. انا طبعا بشكر شركه اندوفيجن من ساوث كوريا ان هي السبونسرنج لي ذيس داي. فان شاء الله نشوف حضراتكم يوم الخميس والجمعه 1 و2/7. شكرا استاذنا الكبير استاذ دكتور ماهر عسال، شكرا استاذنا الكبير استاذ دكتور بهاء قرنه، شرفتونا يا فندم.
ربنا يكرمك، متشكرين اهو، دعوه كريمه، وماهر جمعت لي بماهر لينا مده ما شفناهوش، ربنا يكرمكم ان شاء الله. شكرا. السلام عليكم.
السلام عليكم ورحمه الله وبركاته. مع الف سلامه يا فندم. مع الف سلامه.